Hello and welcome to Dragon Bites, the paediatric podcast aimed at paediatric trainees or anyone with an interest in child health. I'm Hannah Davis, a paediatric trainee in Wales and a member of the Dragon Bites team. This week we have another wonderful instalment from Professor Uzun and our very own Asim Javed, talking about patent ductus arteriosus. Let's get started.
Right. Hello again, Professor Uzun.
Hello. How are you, Asim?
I'm very well, thank you. How are you?
Very well.
I've heard you've had a busy day today already.
It was indeed.
Yeah.
Thank you for waiting.
No, thank you for joining us despite the fact that you've had a busy day. I found out for the first time today that you don't have lunch, you just skip it all together.
I do.
You do?
When you come to my age, perhaps you might do the same. Who knows?
Really?
Enjoy what your stomach dictates you to do when you're young. Enjoy your food.
Fair enough.
Now, food for thought.
Mm-hmm.
We're going to talk about, what is the topic? I thought it was patent ductus arteriosus.
That's right.
And
yes.
AP window.
That's
Is that
right.
correct?
Mm-hmm.
And we decided to leave AV septal defect after this recording because AV septal defect will take at least an hour
Yeah,
discussion.
exactly.
It's a quite major topic to discuss.
Yeah. Mm-hmm.
Shall I start with defining?
Yeah, why
What
not?
do you think?
Yeah, that sounds like a good place
So
to start.
patent ductus arteriosus, as you know, it's one of the three fetal communications. Let me tell you two of them, and you tell me the third one.
Mm-hmm.
One is ductus venosus,
Mm-hmm.
which provides communication between the umbilical vein and the inferior vena cava.
Mm-hmm.
Second one is foramen ovale, provides communication between right atrium and the left atrium.
Mm-hmm.
And the third one is
Well, I assume ductus arteriosus by default.
exactly. So three structures, they are destined to close. And the ductus arteriosus is a tubular structure connecting pulmonary artery to the descending aorta.
Mm-hmm.
Its joining point is either between the two branch pulmonary arteries or lateral to the left pulmonary artery.
Mm-hmm.
And the other end attaches to the aortic isthmus opposite to the origin of left subclavian artery.
Mm-hmm.
So its role is to divert right ventricular output to the descending aorta and placenta, which is oxygen poor blood, to pick up oxygen from the placenta in antenatal life.
Mm-hmm.
It is kept open by mother's enzyme or hormone, prostaglandin, but after birth it's destined to close spontaneously due to excessive amount of oxygen being inhaled by the baby plus lack of prostaglandin. In combination, they trigger ductal closure, initially functional and anatomical closure. If it stays open after birth, then shunt becomes reversed from the left side, descending aorta, oxygenated blood goes into the ductus, through the duct into the pulmonary artery and to lungs, so left to right shunt. So pink blood moves into the right-sided circulation, blue blood. Do we call this abnormal if it is open in a newborn baby?
No, not initially.
Exactly.
Yeah.
So when it becomes abnormal, beyond 3 months of life, if the ductus arteriosus did not close, we call this patent ductus arteriosus. This is by default. So functionally it should close or should become very small, but beyond 3 months of age, if it did not close, it becomes an abnormality.
Mm-hmm.
Do you think it is quite common in certain age groups?
Yeah, well, so I remember coming across patent ductus arteriosus quite commonly when working on the neonatal unit, where we've got a large number of preterm newborns.
Correct. So in preterm newborns, you see it more often. In 5 to 10% of congenital heart disease will be made by a patent ductus arteriosus. If you take 100 babies with congenital heart disease, and 5 to 10% of them, depending on the gestation and the gender, it is more common in females, less common in males. It's male to female ratio 1 to 3. So 3 times more often it is seen in female population.
Mm.
So preterm babies, about half of them will have Ductus Arteriosus if they are less than 25 weeks.
Mm.
Beyond 25 weeks, 26 weeks, up to 32 weeks, it's about between 10 and 30% will have it.
Mm-hmm.
And beyond 32 weeks to 36 weeks, perhaps the incidence drops to 5%, and about 40 weeks of gestation and term babies. At birth, it will be present in most babies, but within 24 hours, maximum in 3 days, if not 3 days, 5 days, it would have closed in majority of patients. Only, I would say, less than 0.5% would remain open
Mm-hmm.
in normal population.
Right.
So patent ductus arteriosus is a normal structure. It becomes abnormal if it remains open beyond 3 months of age. That's what we need to know.
What it comes down to. What's really interesting there, though, is you mentioned that in almost all cases, it seems like it closes within a few days, but the actual definitions for patent ductus arteriosus is beyond 3 months. So that's a huge window which
Correct.
we've left people. Is there a reason for that?
Correct. Similar to foramen ovale,
Mm.
that is the anatomical closure,
Mm.
because ductus arteriosus may be functionally closed, but anatomically it may not have been sealed properly,
Mm.
like foramen ovale. Foramen ovale functional closure occurs within the first few days of life, but anatomically the primum septum and the upper portion of the secundum septum
Mhm.
may not be fused anatomically and glued together,
Right.
and that's why we put this anatomical definition by the previous concept of learning, previous teaching of eminent pathologists and clinicians. That's how they defined it.
Mm-hmm.
So we from the autopsy studies, we know that it takes up to 3 months for the anatomical gluing or fixation occur.
Mm-hmm.
That is the reason we put that.
Excellent. Okay, thank you. That really helps clarify.
Do we call PDA normal in a symptomatic child less than 3 months of age? No, this is still pathological. My point of 3 months, what we call it 3 months of age, for ductus to remain open and cause no problem, it is pathological. But ductus is open and causing problem before 3 months of age, still abnormal.
Mm-hmm.
So we don't call that normality.
Sure.
But there is still a chance for it to get smaller up to 3 months of age.
Right.
But beyond 3 months of age, it's exceedingly unlikely for the duct to get smaller.
Mm-hmm. Excellent. Thank you.
I hope it clarifies that.
Yeah, absolutely. That's brilliant. Thank you.
And now, when we talk about what it is, when we talk about its function, as we mentioned, to divert right ventricular output. So right ventricle contributes 60% of cardiac output in fetal life, as opposed to 50% postnatal life, of which 10% goes to the lungs, and 50% of RV output bypasses the lungs through the ductus down to the descending aorta. And that is going to pick up oxygen from the placenta and will come back to the left side. So its role is to work like a bypass machine and to convey deoxygenated blood to the placenta, which serves as baby's lungs. Postnatally, of course, the shunt is reversed. There is no placenta. Lungs are working. Hence, the lung pressures are lower and the systemic pressures are higher. And the discrepancy between the two is massive. So 10 average lung pressure or RV or pulmonary artery pressure, and the systemic pressure over 70, 80, up to 90 in newborn babies. So 90 and 10, there is 80 millimeter of mercury pressure gap, and hence the circulation will be moving from left to right. And it's that's why we call it left to right shunt following birth. Does it cause also right to left shunt?
So it can do in certain circumstances. So if you have persistent hypertension of the newborn, pulmonary hypertension of the newborn, then you'll have ongoing high pressures in the lung field. So you could still have a right to left shunt.
Brilliant. And how about in patients who had Ductus Arteriosus and the shunt initially was left to right, and baby wasn't picked on earlier, and baby is now 1 year old and very scrawny, faltering growth, and mom said always had frequent chest infections and breathless, and the child comes to you. Would you expect in this child a little bit cyanosis, a little bit clubbing, and right to left shunt perhaps?
Yeah, because I suppose with that ongoing initial left to right shunting, that puts increased pressure on the right side of the heart and into the pulmonary vasculature, so that might end up increasing resistance that side eventually,
Yes.
leading to a reverse of the shunting.
What is it called? There is a name for it?
Eisenmenger's?
Wonderful. Eisenmenger syndrome. That's brilliant. So the Eisenmenger syndrome can occur in patients with Ductus Arteriosus. Then the shunt may become right to left or bidirectional. Sometimes it can happen earlier on, especially in babies who have upper airway obstruction, obstructive sleep apnea, large tonsils, or airway problems. So in those babies, sometimes pressures inside the lungs may appear elevated. Then you shouldn't jump to the conclusion that this baby has established pulmonary hypertension. And in those babies, you should have open mind and exclude reversible causes of pulmonary hypertension, such as obstructive sleep apnea and nasal obstruction, lung pathologies. It would relieve the stress in the parents as well as in the medical professionals that this PDA is amenable to surgery or surgical ligation. And Eisenmenger syndrome has not developed in these babies, but it may mimic it. However, in those babies, you wouldn't have seen clubbing.
Right.
Clubbing to occur, you need at least 6 months. And in fact, most often it doesn't occur below sort of 12 months of age. So that's one thing to remember. Sometimes you can see bidirectional shunting or right to left shunting even in small babies with other pathologies. So a baby with PDA at birth would have some subtle signs and symptoms, maybe totally asymptomatic when you look at the baby, depending on the size of the ductus, one, depending on the magnitude of shunt, and depending on the pulmonary vascular resistance. Like in VSD.
Yeah.
When the PVR drops, pulmonary vascular resistance, then the left to right shunt would increase and baby would become breathless. Do you remember when PVR starts dropping and normalizes at what week of gestation? What week of age after birth? First week? Second week?
No, I think we're looking a few weeks old, aren't we? So isn't it from 3 weeks plus that you start normalizing?
Shouldn't be more than 3 weeks.
Okay.
Usually within a week, in the majority of babies, PVR would drop to normal.
Oh, right, okay.
In other small percentage of babies, it may extend up to 2 weeks. Beyond 3 weeks, if the PVR did not drop, you should be worried about it. So those babies become symptomatic within the first 2-3 weeks of life. So some babies second weeks, in some babies third week, some babies of course maybe later if the size of the duct is not big.
Right.
So as I said, there are 3 factors there. So if the duct is small, what sort of murmur you would anticipate in these babies?
So I suppose if it's a small duct, would you get quite a harsh murmur?
Probably you would get ejection systolic murmur or systolic murmur if it is small duct, and diastolic component would be very faint, even if you had the diastolic flow. If the duct is slightly bigger, then the flow is higher, and you might be able to get continuous, continuous flow, and therefore you might get good going systolic and diastolic murmur. If the duct is too big and babies develop pulmonary hypertension, then the murmur may be just systolic, and you may hear this time a loud second heart sound, as it was mentioned in VSD patients and other left to right shunts.
Mm-hmm.
Similar pathologies.
Yeah.
If the duct is not causing pulmonary hypertension but congestive heart failure due to excessive flow, high velocity jet, low PVR, high volume blood, so resulting in congestive heart failure,
Yeah.
in those babies you hear a typical murmur.
Mm-hmm.
There is a name for it.
So would this be the machinery murmur?
Wonderful, absolutely. Once you hear that machinery murmur, you would never forget that.
Mm-hmm.
Typically, that murmur is below the clavicle, because remember, duct extends from anterior pulmonary artery backwards to the aorta, hence moves to the left side. So along the clavicle, so below the clavicle, towards left from the pulmonary focus. So under the clavicle, subclavicular region is the typical region for ductal flow. Sometimes you may hear it at the back, and so you should listen to that area too, in my view. So murmur is typical in babies with obvious and large duct with continuous flow, high velocity, no pulmonary hypertension. So you only see these babies with failure to thrive, breathlessness, congestive heart failure. But if the baby doesn't have congestive heart failure, has balloonus, or murmur is just systolic, then you can assume that the duct is still big, and diastolic component is probably low velocity as a result of very little pressure difference between pulmonary pressure and the systemic pressure. And hence hearing just systolic murmur and quieter shouldn't suggest automatically this is a mild lesion. That's what I'm trying to get at.
Yeah.
The louder the murmur, narrower the ductus arteriosus. If you hear loud murmur in systole and diastole, and the baby is also breathless with intercostal recessions, that indicates not only the size is big, but also amount of shunt going through is important, and the speed of blood going through the duct is also quite high. So you need to have all these combinations. So baby has small duct, and the murmur could be only systolic. And the systolic murmur may be faint. If the duct is silent duct, you may not hear any murmur. So we call that silent duct. It is only visible on echocardiogram as a trace of color, but no murmur. If you hear a murmur and you can see the duct on echocardiogram, and you call this small duct, you don't call it silent duct.
Sure.
If the duct gives you diastolic murmur, starts giving diastolic murmur, it indicates that the size is big enough and the blood push through the duct is important. So if you start hearing systolic and diastolic, you stepping into another territory. The duct is becoming clinically relevant, important. So systolic murmur alone may not suggest very big murmur, very big ductus, very big lesion. Depends on the harshness. If the murmur is loud, harsh, and baby is having also failure to thrive, feeding difficulty, obviously systolic murmur alone may suffice to say this is an important duct. Because diastolic components sometimes may not be appreciated by an inexperienced person. Or due to various reasons, you may not be able to hear it. If your stethoscope is not very good, if baby's chest for some reason has some other pathologies, fat tissue, whatever, or has got some lung inflammation, we may not be able to appreciate the diastolic murmur. And if you move to the fourth category where there is reversal of shunt, systolic murmur, not loud this time, just fairly easily audible, but there is also loud second half sound. Now you're stepping onto a more dangerous zone. So there are 4 steps.
Sure.
Can you tell me the 4 steps again? No murmur.
So no murmur, but visible on echocardiogram. So that's a silent duct. Then you've got a small duct, where you can hear a murmur, but when you check it on an echo, it's quite a small flow from it. Then you've got a more significant duct where you've got both systolic and diastolic sounds, which shows that you're now entering around where it might be pathologically significant. And then finally, you can have a really large duct where you might only just get a systolic component. And even though the murmur might be quieter, that might actually be a reflection of how large the duct is.
Excellent, brilliant, absolutely wonderful. So these babies, sometimes with loud systolic murmur without diastolic component, again, as I said, may fall into important category, as we mentioned, because the observing individual or examining individual may not be able to appreciate diastolic murmur.
Yeah.
So lack of diastolic murmur should not mislead you, as if this is not an important duct.
Sure.
Remember. But before we went into straight into examination, but beforehand, auscultation. Beforehand, we need to look at and observe the child. On observation, what do you expect from these babies in those 4 categories?
So I suppose
Maybe
at the less significant end of it, they might be completely symptomless.
perfect.
Yeah. Then perhaps you might be looking at probably a lot of what we discuss with VSDs.
Correct.
So,
What are they then?
breathlessness.
Good.
I remember difficulty feeding.
Excellent.
And then in the long run, poor growth and poor weight gain.
Excellent. And how about feeding? Shall we elaborate on that again?
Yes.
Just recap.
Just to recap, I think that the key things we found with feed is, if they're breastfeeding, they have very short latch times, lots of stopping between feeds, because they find that the work of breathing goes up during a feed. They might become really sleepy post feed because they're getting very tired. If they're bottle fed, you find that they're feeding very small volumes, never able to finish a bottle.
Fantastic.
Things like that.
Absolutely wonderful. So this is just a recap of what we said before.
Yeah.
Repetition is important part of learning process. Excellent. How about when we observe the child? What sort of findings you would notice on their ribs, on their Harrison sulcus, under the... So would you see any intercostal recessions?
Yeah, so I mean, if it's significant enough and they're getting enough breathlessness from it, then yeah, you'd get subcostal recessions, intercostal recessions, tracheal tug. You could get grunting, head bobbing, nasal flaring.
Excellent. All these usual common signs with any left to right, significant left to right shunts. Absolutely brilliant. How about diastolic murmur? So we mentioned about significant left to right shunt causing left atrial dilatation, huge pulmonary venous return coming to the left atrium, but the mitral valve orifice is same size, and the left ventricle is receiving quite significant amount of blood and with high flow. What sort of murmur would that generate in addition to ductal murmur if you listen to the apex?
So would that be a rumbling murmur?
Absolutely wonderful. What a fantastic remembering. So we call it systolic rumble or diastolic rumble?
Diastolic.
Wonderful. Round of applause. Brilliant. Diastolic rumble. And if you hear diastolic rumble, always remember Asim and Dr. Uzun, because once you hear that, it means that your ears now are beautifully programmed to hear even subtle.
One day I hope to hear it, so as I can.
We should all hope. We should all hope.
Yeah.
And how about pulses and the precordium? What do you expect in these babies?
So they probably have a very active, particularly if it's an active duct, they'd have a very active precordium.
Wonderful.
And then pulses, would they have particularly full pulses?
Wonderful. What we call it?
Bounding?
Bounding pulses. What is the mechanism of bounding pulses?
It's because there's this wide pulse pressure, isn't there?
Excellent pressure gap. Systolic pressure is high, diastolic pressure is lower. Why?
Because of the shunting during the diastolic process.
Absolutely wonderful. I don't know why we're doing this podcast. You could do it yourself. I don't know whether you need me.
Far from the case. I'm only getting these answers because you're leading me to them, Professor.
You're very modest. Okay, excellent. So you must make sure before you put your stethoscope, if you have not reached the diagnosis with 50% certainty, go back and repeat what you have done. So feel the pulses, feel the chest, look at baby's development, examine the child from top to toe, and also put them together with patient's history.
Mm.
And if you couldn't make the diagnosis 50%, that you are going to listen and hear continuous murmur in the subclavicular area, then you should go back.
Mm-hmm.
So that is my advice to you.
Mm-hmm.
You've got to channel yourself into those 4 categories I mentioned to you. 4, in fact, there are 5 reasons, but what I said to you, there are 3.5 reasons, or we call it 4 reasons. In my opinion, 5 categories of breathlessness in children. 1, left-sided obstructions, coarctation, aortic stenosis, hypoplastic left heart syndrome, whatever. Mm-hmm. Those are more common within the first 2 weeks. Beyond 2 weeks, when PVR drops, then left to right shunts. Mm-hmm. Well child or pink child, breathless, then you need to think of VSD, PDA, AP window, whatever. Mm-hmm. And the third cause, what we said, is primary myocardial problems. Mm-hmm. Cardiomyopathy, myocardial infarction, ischemia, so on. And the half the cause, or the fourth cause, total anomalous pulmonary venous drainage, which is left to right shunt, but then right to left shunt, with obstruction. Mm-hmm. And those babies would look blue as well as breathless, but they can be as pink as 97% saturated.
Wow.
TAPVD. And the fifth cause is tachycardias, arrhythmias. Mm. So in these babies, we examined, history didn't suggest any arrhythmia, and the baby is not blue, and the pulses are bounding, precordium is active, so it's telling you left to right shunt. Then you're going to think, I will hear either a pansystolic murmur, or I will hear a continuous murmur below the clavicle. Mm. You must say that to yourself.
Yeah.
So you heard the machinery type murmur, and you're almost certain. Then you want to make sure that you completed all the examination investigations. You will order a chest X-ray and ECG. Mm-hmm.
Pace yourself, we have our second part of the patent ductus arteriosus talk to follow next week. Thanks again to our speaker, Professor Uzun, and thanks to you for listening.